wonderful day on 2/2/22. I welcome you to our Steadtalk here from the beautiful Seattle Science Foundation. A shout out to our wonderful crew here at the Seattle Science Foundation. They're amazing people, and they've carried us now 2 years through the COVID crisis and its permutations. Steadtalk, spine technology, education, discovery, discussion, debate is a very wonderful format that's really kind of taken off. And we welcome all of you around the world who are following us. And I'm looking forward to interacting with you on the chat line. Today's lecturer is Dr. Zane Tymchak. He's one of our faculty here at the Swedish Neuroscience Institute. He's a graduate of the University of Saskatchewan. I'm going to introduce him in greater detail later, but he's unique in that he's dual fellowship trained in vascular neurosurgery and in spine surgery. And we invited him to enlighten us about the crossover phenomenology, symptomatology, and treatment of spine conditions that go into the vascular realm. And there'll be a couple of tangential questions also. And as always, our excellent fellows have prepared a couple of cases. Some are directly vascular surgery or aligned. Some of them are a little bit more obliquely aligned in that realm. Maybe I'll ask Jared Cook to start off things. He was in the operating with me late last night. So the cobwebs in our eyes are explained by that, but he put together a case that we just finished very recently. So Jared, take the lead.
All right, hello. I'm Jared Cook, orthopedic spine fellow trained in Las Cruces, New Mexico. So this is a patient that we took care of yesterday. Well, multiple times, but last one was yesterday. So he's a 65-year-old male with chronic neck pain, dysesthesias, bilateral upper extremities, pain mostly in C8 distribution, dysphagia and hoarseness, and multiple injuries to the neck in the past. And a remote history of ACDF of C6-7 and then ACDF of C7-T1, the point where he eventually ended up in our facility. So there is some weakness, mostly elbow flexors and finger abductors and grip strength, and a little bit of sensory changes. And so here's what the original films looked like when the patient presented. So you see the two prior surgeries is kyphosing over the top and has a large anterior osteophyte complex. He's also having some swallowing difficulties, whether or not that contributed. And
yeah. So let's go back here just for 1 second. Here is Dr. Tymchak. So you're dual fellowship trained and spine trained. In your education, excluding any influence I might have, what do you think about these two kind of non-connected plates? I know there's one of our partners, Dr. Hart, who likes that, but what are your thoughts on this concept when you see something like that?
The two surgeries were performed on separate occasions, like two prior surgeries. Yeah. I can see why one might consider doing that from a technical perspective. It maybe makes things a bit easier versus taking out the old hardware and putting in new hardware. I've heard about the theoretical biomechanical advantages, but in my hands, I don't think this is something that I would do. Not necessarily that it's the wrong choice all the time, but I wouldn't do that myself.
For me, this is also very evocative of a fundamental insight voiced by, I don't even know who said that first, but to my memory, Dr. Kostwick from Canada actually was the first one to say that. And he said, any fusion surgery is a deformity surgery. And certainly this kyphosis between these bottom segments at C6 to T1 kind of induced significant counter reaction at the levels above, as you see at 4, 5, and then above. Okay, carry us on.
Okay, so the patient was revised at that point. So this was the procedure went C4 to C7. There it was done, because of the history of multiple surgeries, was done with an ENT approach surgeon. There still ended up being a vertebral artery injury that was that was embolized.
So tell us, so this is where I want to kind of intervene here. So Dr. Tymchak, this was an intraoperative vertebral artery injury during the revision decompression part. It was immediately contained. I don't think there was much blood loss.
Yes.
We did have imaging that identified a codominant vertebral artery setup, but just very briefly, what should we do outside of containing the bleeding when we have an intraoperative vertebral artery injury? What outside of containing the bleeding, no particular matters, what should we do?
Well, I think for starters, you notify anesthesia and call a colleague to help. Get another pair of eyes instead of experienced hands in the field. And once you've obtained proximal control, if you're able to explore the rent or injury to the artery, one can consider primary repair in a situation where you are aware of the dominance of the vertebral artery and it's codominant. You can be pretty safe in terms of knowing that you can sacrifice the artery. At that point, once you've had bleeding under control, then I would complete the surgery and take the patient under the same anesthetic to a neurointerventional suite to interrogate the vertebral arteries in the posterior circulation, make sure you haven't caused intracranial thromboembolism, which could require thrombectomy. And then in that situation, you can consider additional interventions if you've had to sacrifice the artery, coil off the vertebral artery or place some sort of a plug. In a situation where you have injured the dominant vertebral artery, then you have to make every attempt to try to repair it or potentially take to the neurointerventional suite and stent, which would be less than ideal given the recent surgery, but might be necessary.
So note here, the patient was scheduled initially to have a surgery done anterior posterior, and we had to alter the intraoperative had to alter the surgical plan. Mm-hmm. So we just concentrated on the C4 to C6 segments. We did not attempt to try to take that graft out at the bottom, although it would be not in vertebral artery territory, but we want to kind of limit the surgery. And we did not turn the patient over and do him prone. You agree with that kind of a plan there, Zane?
Yeah, I think once you complete the anterior part, I would take to the IR suite. And then once you've had a chance to wake the patient up, you can always bring him back for a second stage down the road. I think that's the safest thing.
And just to editorialize, that had been the plan, but we didn't do that.
It's a little bit more fun.
Yeah,
so because of what happens out there in the last 2 years, that second stage of the plan kept getting pulled away from us, let's say.
The posterior surgery had been canceled several times, and the patient had a severe C8 T1 EMG documented radiculopathy. Okay.
I was trying to be coy about it. So just pay attention, right? Where's the mouse? There it is. Pay attention to this little pseudo right over here. So while waiting to be able to do stage 2, there was a collapse into a new kyphosis. So obviously problematic. And so when we were able to get him in yesterday, basically we had to correct this deformity. So here's intraoperatively basically how that was done. Went from C2 to T3, and got the reduction maneuver was lock the rods down into the cervical lateral mass screws, and then so that's what you're seeing in that first panel. And then as the thoracic screws were locked in, or as the rod was locked in the thoracic screws, the deformity corrected. And then post-operatively, we have the CT scouts, but I think these are nice and representative of what we had there. Did take an osteotomy to do, but got them nice and aligned and supported, and the surgery is finally complete.
Do you remember which side the vertebral artery injury was on?
I want to say it was the right.
Right side. And so posteriorly, we were very careful with what side?
With the
Left side.
the one with the patent vert.
Yeah. So he actually did quite well. We did a posterior C71 osteotomy. Zane, any thoughts? Were we reckless to put long screws in on the left side like this? They're all good on CT, but what are your thoughts when you have a patient with a unilateral persistent vertebral artery injury? And what kind of studies should we get beforehand to kind of make sure that we understand the updated circulation?
Yeah, I would get a CTA, and depending on the anatomy of the foramen at the level of C2 and the course of the vertebral artery, you can, if it was me, I would go on the safe side on that side that had a patent vertebral artery and put in a short screw. But clearly, you went for long purchase, good instrumentation and purchase, and I think that was, you wanted to do that to support your construct, which I think is a fair assessment. And as long as you do it safely, get a true lateral X-ray of C2. And I had the opportunity to do these screws with you, Dr. Chapman, and the way you do it, I think, is very safe. Almost regardless of what the anatomy of the vertebral artery is like. Yeah,
that careful, 1-2 millimeter at a time. Not just going forward with a drill. It's a lot safer.
Did you consider translaminar?
Absolutely. That was our bailout option, but again, we felt very comfortable with this corridors. And again, we did I know there are a lot of folks who want to drill 4 and 8 millimeters, but we drilled very carefully and probed, and we felt we had a safe interval. But you're spot on. That's definitely a very reasonable option. And he did actually quite well. So again, the C71 posterior osteotomy is like a shortening osteotomy, but we put actually a whole banana cage in from the side. We worked between the vertebra, and we did not put screws in the T1. We resected the T1 pedicle, and that gave us a very nice corridor between the C8 and T1 nerve roots to put a cage in. Did you feel we had to do any excessive nerve root manipulation?
No, everything, you could clearly see everything. It was all well visualized, not under tension. We didn't have to do any nerve root retraction. It was easy to just protect, without any tension. So yeah, not a concern.
Great. Okay. Any other comments, Zane?
No.
So yeah, cervical thoracic junction. And again, we have to be very aware of vertebral arteries and study them beforehand. And I don't remember how the vertebral artery injury occurred, but it was, I think, during a partial resection of the uncovertebral joint. And there was local containment obtained. We called our vascular surgery colleagues, and we're very lucky here at SNI to have excellent vascular surgery colleagues from our neurosurgical department right there next to us, and beautiful hybrid OR. So literally right after a procedure is done, if need be, we can take them over to the vascular suite, and our vascular surgery colleagues can help us make sure we understand what's going on and intervene if need be. Any learning points for you, Jared?
One regarding the vertebral artery injury, although I wasn't, there for that stage of the case. I think that's an important lesson of what you guys were talking about. But also when trying to do this, deformity correction from posterior, I think, doing that osteotomy with the banana cage, that's actually, it's very good technique at the junction there, and got good correction out of it. So.
All right. Thank you for this startup. And next, we'll have Dr. Jerry Robinson. Appreciate it, Jared, and good work yesterday. Dr. Jerry Robinson is a case with a different slant in a different area, and that pertains to anticoagulation problems or excessive coagulation.
All right. My name is Jerry Robinson. I'm one of the Swedish orthospine fellows here. I'm from Akron, Ohio. So the case I'm presenting is a 38-year-old female with about 2 months of numbness in bilateral lower extremities and weakness. She, of note, had a recent fall with a non-displaced posterior malleolar fracture that was determined to be non-operative and was treated in a boot. So she does have a risk factor for being immobilized. However, she presented to the ED for 24 hours of urinary retention, weakness, and increased in shortness of breath and chest pain. She was an independent ambulator 4 months ago. Of note, does have a BMI of 50. No other significant past medical history, but you can see the exam here on the right with essentially what seems to be like an Asia C type picture in the lower extremities, as well as decreased sensation in the saddle and perineal areas. And then there's the posterior malleolar fracture, just for completeness sake for anybody watching. They were found to have a saddle PE and received TPA immediately. I don't look at a lot of CTAs, but even I could see this filling void defect throughout the CTA. And then of note on the CTA, they were found to have this incidental finding of this at T1011.
And what is this?
And we can see a calcified disc herniation, maybe some acute on chronic chronicity to that with some disc herniation, and the calcifications indicate it's probably been going on for a while.
Can you just humor us all, Jerry, and with your cursor outline the saddle embolus, which is pretty substantial?
So you can see this filling defect in the arteriogram here, and you can see that it kind of flows through the main pulmonary arteries and then into the lower tributaries of that.
So, and this patient was actually in extremis. She didn't need CPR, but she was very sick. She was severely hypotensive, hypoxic. And was she intubated actually?
I don't believe she was. Initially, she was in extremis on her way to that, but apparently was a very excellent responder to the TPA and had a very dramatic turnaround in her cardiopulmonary status.
Yeah, so she was resuscitated in one of our ERs, and immediately they were amazing. They recognized this consequence of ankle fracture, sedentary position, very large woman on, I think, birth control also, no smoking history. She's actually a nurse. And the response in that ER, this is one of the Swedish ERs, was nothing short of phenomenal. I mean, from starting TPA and putting her on pressors, and I think they gave her a Venturi rebreather mask or something like that. She oxygenated pretty rapidly again, was transferred into a cardiac ICU. Now the kicker is they found what the key of this whole thing is. Now take your cursor to the right side and just outline what they incidentally found on the CTA. And what is this again?
Calcified disc herniation of the thoracic spine. T1011.
Great. So now let's go to the MRI.
So the patient was taken for an MRI. Here you can see the representative cut of the axial image corresponding to the T1011, and then that corresponds to this. This is not a myelogram. That is actually the calcified disc herniation in the central canal.
So, Dr. Tymchak, we're showing you this case because of a problem that we face a lot. And if you can go back to that thoracic MRI, it's nice to have that plan slide, but this is probably even more visually evocative. So, Zane, here we have a patient who has just escaped death, literally, and this is not being dramatic. This is truly emergency medicine at its finest. They saved a life, and that of a pretty young mother. She's 38?
Yeah, 38.
Very large, but extremely bright person, family, mother, nice family. And she's acutely anticoagulated. And now we have a patient who's severely myelopathic. She's paraplegic. The origin of this whole thing was this disc herniation, which led her to stumble more and more, caused her ankle fracture, made her sedentary. She had no idea about this whole thing. Very stoic woman. Could be a Canadian almost. Now, the question to you is, first of all, tell us what TPA is and what this means if we wanted to do acute surgery.
So it's a lytic agent that is used in the situation of acute, thromboembolic complication. The world that I am in, we use it in acute stroke. I'm not entirely sure of all of the indications for pulmonary embolism, but clearly it was indicated in this case. In terms of surgery, typically, the actual mechanism of action, half-life of TPA is very short. In a matter, I think it's clears in about 7 to 15 minutes or something like that. It's very short. But having said that, there's a secondary ongoing lytic effects that continue on for probably up to 24 hours. In stroke, we typically hold any additional antiplatelet or anticoagulants for 24 hours after the administration of TPA. And, usually surgery is tried, if possible, we try to delay it at least until then. In her situation, given that she's going to have to be anticoagulated, it makes timing for surgery challenging.
So tell us what we did, and again, what specifically was considered in regards to her anticoagulation needs and status.
So the patient was eventually placed on a heparin drip for anticoagulation. And then there was a heavy discussion about timing of surgery. I believe that the final timing of surgery was around somewhere in the 24 to 36 hour mark, like maybe the 24-hour mark after the TPA, I think. And so the patient received steroids, a T8 to L1 posterior fusion with laminectomy and a transpedicular decompression, and then resection of that calcific disc with an interbody. And then we used an endoscope here with the, I kind of labeled the endoscope picture of, to just confirm the ventral decompression of the thecal sac.
So can you keep that there? So Dr. Tymchak, I know you trained in Canada, also in one of the premier programs in Saskatchewan. What had you been taught about these thoracic discs? This is a calcific disc herniation. And what are your thoughts in terms of how to do this?
So I think these are formidable lesions and should be approached with a lot of respect and care. The cord is already severely compressed, and her situation clinically manifested as myelopathy. And their reserve for manipulation during surgery is low. So in terms of the traditional teaching in neurosurgery, a posterior alone approach is typically thought to be not the best approach. But that's sort of old school thinking of like just laminectomy, decompression alone. In situations, at the thoracolumbar junction, coming from the front has its own technical challenges, and probably more so in a patient of her body habitus. So posterior lateral type of approach, transpedicular, as you did here, I think is the right approach. You can get a very wide decompression bilaterally, first posteriorly, and then attack it from both sides. And I would back that up with instrumentation.
And again, heparin versus TPA, what are collinearities? What are augmentations? What are some concerns? And obviously, would we use TXA or something like that in a surgery like this?
Well, for heparin, in this situation, if she had a saddle embolism, I would have been consulting with, cardiology or some pulmonology to make sure that she didn't have any right heart strain and such, and she'd be able to tolerate surgery. But assuming that everything checked out and she was, anticoagulated, you just have to stop the heparin about 8 hours before surgery. And intraoperatively, I would use cell saver, other adjuncts. I don't think I would use TXA just because of the acute thromboembolic process that she's undergoing. Meticulous hemostasis at the end of surgery so that you can reinitiate anticoagulation as soon as possible.
Great. And surgically speaking, Jerry, what are some of the main concerns when you identify a large central calcific disc herniation? There's a very practical concern that we always worry about.
So we made sure to keep the maps high to perfuse the cord, and then we created a large void in the posterior, in the posterior vertebral body in that disc space, so that we can get a very wide decompression to avoid manipulating the cord, and then also have something to push that back down ventrally into that void. But we were just very careful, and also being mindful that the calcific nature of it could put you at increased risk for a dural tear as well.
Bingo. Yeah, we did. And this endoscope pictures is done with a 70-degree sinus endoscope, shows that the ventral dural sac is fully intact.
And that's just a sucker tip from the other side of the
Yeah.
decompression to show that you can see all the way through.
Great.
And then there's a follow-up picture.
And we just had her for her 6-month follow-up, and she's actually completely normal.
Yeah, she is a crazy good responder to all interventions so far.
Yeah. We still are working on the weight, but she knows that. Rod, any thoughts on, I know you're a Virginia disciple, these posterolateral transfacetal bilateral decompressions versus the traditional corpectomy model that we're all taught originally in our boards?
I mean, I think you did a great decompression. The key is, I think Zane discussed, I think you have to do wide laminectomies above, below, and then do bilateral decompression and try to get, create a nice cavity to be able to get that disc out. Was it pretty adherent to the dura?
Yeah, we used Roten dissectors, and we started above, started below. We saved the nerve root, I think. We did not
And you
even have
did
to
a
take the nerve root bilaterally. We always start on the less compressed side first, whatever that is here, because it's pretty central, and developed intact dural planes. And the Roten armamentarium has beautiful, as you know, dissectors that allow us with their flexible titanium blades to get into that proper plane. And just very patiently with maps elevated, as Jerry said, you were in on the surgery, right?
Mm-hmm.
And actually was pretty controlled, right?
Did you drill out the pedicle too?
We didn't have to do
You can
much.
kind of
though.
see the,
Yeah, we didn't
So you
fully
didn't go
void
too
here.
far, posterolateral.
And you can
No,
see
it's-
how we created a void here and we filled it up with a spacer. I'm not sure that we had to do that. I just felt better by putting it
Yeah,
in.
I mean, it's a beautiful result.
Yeah, no,
So-
she is extremely happy, completely grateful. She's, as Jerry said, one of those very grateful responders. We obviously hang every amount of crepe onto patients when we do these surgeries. Since we have a vascular surgeon here who's a crossover spine surgeon also, briefly again, Zane, tell us about the Artery of Adamkiewicz and what should we do when we do this dissection. We do a transpedicular takedown, we see the nerve roots, and there's a large pulsating vessel next to us. So where's the Artery of Adamkiewicz? And I've given the proper pronunciation already. And what should we do? When should we order a selective angiogram, etc.?
Yeah, I actually I anticipated this question, Dr. Chapman, and I included a bonus slide in my talk about it.
Excellent.
I'm happy to talk about it now. Or
No,
save
we
it
can
for then.
defer that when you have a visual, but audience members, please remember the Artery of Adamkiewicz will be discussed by a content expert. Any other learning insights for you from your review of this case and re-review now over 6 months out?
I think
What do you
that,
guys do for anticoagulation, just so I can,
so this patient
TPA? then
got
heparin?
TPA and then was on a heparin drip. The heparin drip was immediately stopped prior to surgery so that, you know, we could turn it off and
Yeah.
on very
And
quickly.
then you turn it on right after?
Yeah, and then I think it was, we had an extensive conversation with the ICU and cardiopulmonary team to discuss what her risk would be if we could turn it on at 24 hours or even less. And I think everyone was surprised by her turnaround with the TPA and felt that she could wait 24 hours to then restart. So I think we did wait about 24 hours afterwards, and TXA was not started or was not used for her
And
intraoperative
then what's the
management.
treatment? Coumadin for 6 months?
I think it's considered provoked because she had a
Sure.
injury that caused her to have the risk factors for a PE. So I'm not sure on the exact recommendation of how long they're going to do it. It might be a year or two. I'm not sure if it's 6 months or less.
Transition to some-
Yeah, she's on Coumadin now, I believe, or Eliquis, one of the orals. I
Great.
can't
She's on
remember.
Eliquis, actually.
Eliquis, okay.
Yeah.
Great case.
So yeah, so that was relevant. We just saw her for her follow-up. So this is, I need to stress that the difficulties from COVID were dramatic because her family, and there are many medical members in her family, could not be in the hospital when we had life and death discussions. I want to again say how amazing it is to work in the hospital with cardiothoracic surgeons. We had a cardiothoracic surgeon on standby. We had cardiac anesthesiologists. We asked about preoperative, should we do various preoperative catheterizations and this and that? And they all said no. But we were prepared for war, for an open chest surgery. And fortunately, it was a very uneventful case.
I think there was a discussion for an IVC filter too, and she was not found to have any lower extremity DVT, which was surprising. But I also found it interesting that a lot of the hip scope surgeons I used to work with in orthopedics said you wouldn't use a 70-degree 70-degree scope very often. And so I kind of bragged and sent this picture and was like, well, I used one in the spine. So
We'll use one tomorrow for a similar case.
perfect.
All right. Thank you, Jerry. Now we have 2 surprise cases, and none of us on the faculty at SNI know about it. Yev, do you want to go first? Sure. A UCLA case. So we have 2 surprise cases, and then Dr. Zakhtataran has another case that he promised will wow us, but Yev was so kind to share something from his time at UCLA.
All right. Thanks, Aaron. I'm Yev Fravert, one of the neurosurgery spine fellows here at Swedish, and I'm going to share a memorable case from residency that's spine adjacent, but probably still relevant to the discussion here. And I want to briefly thank my student Daniel for helping me assemble parts of this presentation. So our patient is a 52-year-old male who was followed at an outside hospital for an inoperable brain tumor. He presented to our emergency room with severe intractable nausea, vomiting, and PO intolerance. He also related kind of gradually reduced balance, persistent hiccups, and blurry vision. Over the course of about 3 months, he had 40 pounds of weight loss. On physical exam, his vital signs were normal. BMI wasn't particularly low despite the severe weight loss preceding this. He had downbeating nystagmus, but the rest of his cranial nerves, including cranial nerve 12, were pretty normal. He didn't have any strength deficits, but he did have reduced upper extremity dexterity. His finger to nose was normal. He had increased tone throughout his extremities, patchy hyperreflexia in both the uppers and lowers, negative Babinski bilaterally, and a positive left Hoffman. And this was the imaging that we were able to acquire. And you can see way down there in the inferior medulla, kind of almost at the junction with the C-spine, there's a hyperdensity on the sagittal CT and kind of a heterogeneous lesion on the sagittal MRI.
Yeah, can you go back and just use a cursor, please, just for a second to highlight what is evident to a lot of people, but people like myself benefit from a little augmentation.
Right there where my cursor is on the MRI, and then way down here on the CT scan. This is some additional imaging. That's a contrasted MRI there, sagittal and axial, showing maybe patchy enhancement, and then just the axial cut of the flare on the far right side there. So our initial plan was to refer this patient to a dietitian, make sure we could kind of restore his nutrition a little bit, refer him to ophthalmology for the blurry vision, have him follow up in 1 month, and then perform elective intervention after the clot had dissipated. We had a pretty frank risk-benefit discussion. The differential for this lesion is wide, but most likely just based on imaging appearance, we decided that it was a cavernous malformation. We did have him get a pan scan to rule out metastatic disease, and he also underwent vascular imaging. Unfortunately, our plans were a little bit disrupted when 2 weeks later he presented to the ED with intractable hiccups, further weight loss, and was almost immediately intubated for a hypoxic episode, which presumably was due to Ondine's curse, given the location of the lesion.
Tell us what Ondine's curse is.
Kind of in a general sense, it's just the lack of an autonomic respiratory drive, where the only way that you can maintain respiration is to consciously maintain it, by focusing on it. And this was his imaging at his representation in 2 weeks. The lesion doesn't look particularly bigger. And then on the right side there, that's a vascular CT, not demonstrating any unusual feeding vessels, no unusual DVAs or dilated draining veins.
Did the cerebellum descend, the tonsils, did they go down to the foramen more? Or
there wasn't really much evidence of herniation. I think if you compare that sagittal scan to this one,
thank you.
It's essentially the same.
Yeah, that looks the same. Yeah.
And then,
so we invite Dr. Tymchak to give us a brief commentary on what concerns you as a vascular surgeon in terms of what you're seeing so far.
I agree with the presumptive diagnosis. I think you did an appropriate workup. How old was he?
52.
Okay. And the general thought was that his cachexia was related to this lesion and swallowing difficulties and such?
Yeah, that was what we were working with, and his metastatic workup wasn't entirely complete when he represented to the ED, but at that time there was no significant suspicion of metastatic disease or anything like that.
Yeah.
And Dr. Tymchak, can you educate the orthopedic surgeons amongst us what a cavernous malformation is?
It's a non-shunting vascular lesion. It's a sort of sinusoidal, irregular, venous-like structure. It can be associated with genetic syndromes, but is often sporadic as well. And they tend to be associated with these developmental venous anomalies, which are have an irregular appearance. They look like a shunting vascular malformation, but actually are sort of just variant of normal venous anatomy, and should be spared during surgery. These brainstem cavernous malformations are, notorious, and surgery is technically challenging and then highly morbid, because of the location and the surrounding cranial nerves and eloquent neural structures. And typically, you oftentimes don't operate on these after first presentation. You wait until they extend to the PL surface and then attack it through that corridor.
So Dr. Dekutowski has asked two very important questions. Dr. Frevert, did the patient have a gag reflex? Was there any history of hyponatremia?
When he initially presented the first time, many of his electrolytes were abnormal because he'd been vomiting for many days straight without any significant PO intake. The second time he presented, it was more of a respiratory presentation rather than hyponatremia or anything. And we did, at his initial presentation, his electrolytes were normalized prior to discharge. And then in terms of the gag reflex, he was surprisingly, his lower cranial nerves were surprisingly normal. His tongue was midline. I didn't see any abnormality of the palate. We didn't like actively test a gag reflex on an awake patient, but he didn't give any history of aspiration or anything along those lines.
And he was not intubated when he came back, or did you intubate?
So the second time he came, when he represented, he had intractable hiccups, and then in the ED they noticed that he was having these intermittent hypoxic episodes, and one was particularly bad, so they just intubated him for safety. And Dr. Tymchak touched on a very important point. These lesions tend to bleed and rebleed. It's very high value real estate in the brain, and the surgery isn't benign either. So our risk benefit discussion, when I spoke to this patient, was very, very frank. For a 52-year-old, his life expectancy is maybe 30 or so additional years, and I explained to him that the surgery would take most of that risk and put it up front, with the general idea that it would reduce the global risk by taking care of the problem right away. So after we acquired this imaging, we did take him to surgery. The intraoperative plan was to have extensive cranial nerve monitoring. We were going to perform a C1 laminectomy with a suboccipital cranie. I had navigation and ultrasound available, and I planned to perform a midline myelotomy with a microdissection of the lesion, with a subsequent dural repair. Conveniently, as you can see here, the lesion actually had come to the PL surface, and I didn't need all of those fancy techniques to find it. You can appreciate the hemosiderin staining there just below the
Sorry,
tonsils.
what you're manipulating, that video is very cool.
Those
Can
are
you tell us what that is?
Those are the cerebellar tonsils.
Good.
So to the right is inferior. So that's the medulla transitioning into the upper cervical cord near those cotenoids there on the right.
Can you play that video one more time? And
Sure.
then just, if your cursor is mobile after you
Let's see if
use that neural dissector. Yeah. So
right here.
is the lesion, where's the lesion now? Right there?
So you can't see the lesion quite yet, but it's right there, and it has come to the surface. I have more video where you can see it better.
Great.
So this is after a little bit more dissection, and this is the superficial development of the plane. Because we didn't have that month or so that we were hoping to have, the lesion was still pretty stuck on. So it took quite a bit of careful dissection to separate it from the surrounding brainstem. And then this is kind of the final step where I'm delivering the lesion from the medulla.
How much bleeding was there? I mean, this is amazing hemostasis that you have here, because I've heard of these cavernomas being disastrous.
You know, I have seen a few cav mals that bled very heavily, but usually they tend to be, especially once they've like kind of in the post bleed period for the first few weeks or months, they almost auto-necrose until they redevelop. So this one was not particularly bloody.
And do you use a high blood pressure for this, or has your pressure?
No, we keep the patient normotensive. You know, we were ready to raise the blood pressure if there were changes in signals or something, but thankfully we didn't encounter that. And I also had, you know, I had a neurostimulator prepared because if the lesion hadn't come to the surface, then I would have needed to find a safe zone for entry into the medulla, but I didn't end up needing to use that.
How do you know that you've achieved the complete resection?
So there's a couple ways. I don't have the rest of the video here, but you can examine with the scope. You can actually see pretty well inside the cavity. Then you can take an ultrasound, flood the field with saline, and look for residual tissue inside the cavity. And then if you are really suspicious and aggressive, you could do ICG fluoroscopy to see if there's anything unusual lighting up in the cavity, although these tend to be low flow lesions, which wouldn't necessarily show up with that technique.
So let's ask Dr. Tymchak, any thoughts? So obviously this was beautifully done, but also a little bit lucky in light of the fact that there was not a need for myolotomy. Any thoughts on surgical strategy, intraoperative troubleshooting, et cetera?
It looks like you guys did a great job, and you know, I think I would have done exactly the same thing in terms of once you're in there and trying to determine whether or not you've had a complete resection, especially in these locations. It's always tempting to be less aggressive because you don't want to cause harm. But having said that, you know, you're there, you want to get it all the first time, and you don't want this patient coming back with a recurrent hemorrhage. So I think you have to be more aggressive than you would like to be. And that's sort of probably comes with time and experience, which I'm still certainly learning. And in this location, in the brainstem, or you know, in the cord, you don't have to resect the hemosiderin stained surrounding tissue either. So you can leave that alone and just resect any grossly abnormal cavernous malformation like tissue.
How helpful is the ultrasound in this area? This sounds like a daunting area of anatomy to try to differentiate normal or brainstem from abnormal tissue, or am I wrong?
I think you know, depending on how liquefied the clot is going to be, you know, the echogenic nature of fluid versus tissue is going to be quite noticeable. If it's still quite an organized clot, you can often see that and differentiate that from the normal spinal cord or brainstem structures as well. But it might become a little bit more difficult in that situation when the clot is fibrous and more tenacious.
Yeah, I was happy that I didn't need to use the ultrasound. The lesion was you know, there was a very small region where it had breached superficially, but that was enough to develop the plane.
Beautiful.
Postoperatively, we achieved a complete resection, and then you know, when the patient was recovering in the PACU, we were paged urgently by one of the nurses for severe dysarthria. And when we ran down to see the patient, we were very happy to see that she just confused his British accent for dysarthria.
British accent is very vague. Was it Liverpudlian? Was it Manchurian?
So I can specify, but I think if I get any more specific, I'd probably be violating HIPAA. So I'll keep it I'll keep it vague. The patient's hiccups, apnea, nausea, vomiting all went away within 24 hours. His vertical nystagmus actually took a much longer time to go away. It was still residually present at 6 months, and it interfered with his driving for a while. On pathology, tumor staining was negative, and the necrotic tissue did resemble a Capmal, so a path was comfortable calling it that. And then finally, a few months after we were done, we got a very nice thank you letter from the patient's mother, which was the cherry on top of this successful case.
That's great that you photographed that. So very cool case, beautiful pictures, and obviously superb care rendered by you and your team there at UCLA. So thanks for sharing that. So any other insights from your end in terms of the presenting symptoms and how logical this was, and what's the recurrence rate? What do you tell them about follow-up MRIs, et cetera?
So, these patients do need to be followed closely. And if they're, I had a pretty frank discussion with him. If that MRI was anything other than perfect, I probably would have taken him back. The consequences of a rebleed, especially if he's far away from medical care, if he bleeds and develops a repeat compression there, he could go apneic and die immediately. So it would be much better to take the hit and do the redo surgery to salvage whatever was left. And I also agree with what Dr. Tymchak said. It's very, very tempting to go after the hemosiderin stayed tissue, but in this region of the brainstem, or in the brainstem at all, that's not a viable idea.
Well, super well done. Thank you. So now, applause. Let everybody know there was applause in the audience, spontaneous applause. That's the problem of these televised conferences. So now we have, in recognition of the 2/2/22 special day, something new, a surprise case. Nobody but the speaker, Dr. Tatarin, knows what this will be. And are curious what this means. And he passed the McAfee security check.
I've passed the test. We had med students last week, and the first case was kind of more for them, but it's an interesting case. I have two cases. It goes over the cervical spine exam. So this might be redundant for some, but it's interesting. So see if this tricks you. So this is a 54-year-old healthy male presenting with neck pain. He's got left arm pain, numbness, tingling. This is all exacerbated by coughing. And he's noticed that his left arm is weaker over the last couple months. Just a brief touch up on the cervical spine exam. Dermatomes, I always found it very confusing the way they're kind of patchy and laid out. But if you think of a human as a quadruped and look at a dog and look at how they're all vertical stripes,
wow,
and it makes sense. And then if you look at a human in this position, also very similar. So an easier way to remember.
That's cool.
And I will skip through these real quick. I went through the cervical spine exam, the motions you use and the muscles tested. So C4, C5, 6, 7.
Your C8 is working very well there. You're clicking very rapidly.
So in summary, the cervical spine exam and other reflexes tests. I wish the med students were here.
We have actually a student back there, but yeah, carry on.
Patient exam, numbness of his left thumb, all the fingers in his left hand, not the palm and like the dorsum of his hand, and the medial lateral forearm are numb. He's 4 out of 5 in his left wrist flexion and extension, 2 out of 5 in his left triceps, biceps, brachioradius, and deltoid. Reflexes are a little confusing. He has increased DTRs and bilateral lowers. Toes are upgoing on the left. Brisk upper extremity reflexes, negative Sperlings, negative Hoffmans, negative Lermites. Plain films look okay. MRI, this is sagittal T2. Those arrows correspond to the 3 axials shown on the right. So given that he's got progressive left upper extremity weakness, this scan and the exam that I said, what would you want to do?
EMG.
Good. EMG was normal.
All right. It doesn't match. So this is a classic problem.
Okay.
I would not jump into surgery.
I've tricked people into doing a front back with this case. So patient course, EMG was normal. He got NSAIDs. His numbness got better. Weakness persisted. Showed up in the ED 2 weeks later with now progressive lower extremity weakness and unsteady gait. He had an MRI, was unchanged of his neck. You want to jump into a front back now? No.
Thoracic MRI.
He also on a history mentioned that he's had a deformity in his skull and his right parietal bone, which he's had for years, and he has headaches that get worse when he Valsalvas. And this was the subsequent head MRI. So
what are we dealing with? Wow. Dr. Tymchak, I need your help. And what was wrong? How could we have missed this in the beginning?
Yeah, I think that's whoever decided not to jump to surgery made the right decision. And I think a lot of people would be fooled by that MRI because it is, it was an abnormal cervical MRI for sure, but it didn't fit with the exam. So, yeah, I'm not sure what's going on here, to be honest with you. But
yeah, he had meninges. They were taken out. He got better. So that was case one, highlighting the importance of a good cervical spine exam because his findings did not match with his scan.
Just briefly, what should have tipped us off that there was not a cervical spine pathology? Because you obviously showed something that looked like a C6 radiculopathy by your description. What in the exam, as you presented, was abnormal?
Let me go back to the exam. And my second case is more vascular related.
Okay, yeah, so we can fast forward, but just briefly, don't go for other slides. What?
Essentially, the reflexes didn't really make sense.
Okay.
He was brisk in his upper extremity reflexes where you would have expected him to have deadened upper extremity reflexes. And he didn't look like he would be myelopathic from his scan, but he had very brisk, heightened lower extremity reflexes on his exam. Also, his numbness didn't really fit a dermatomal pattern. This second case is more vascular.
All right.
Oriented.
So Dr. Screw and I are not on the hot seat. Dr. Tymchak is.
So this is a 69-year-old ICU nurse who's had 3 months of neck pain, transient dizziness, confusion, poor balance. And this correlates with tingling sensations in her arms and legs. And she's had some dysphagia. So this is her cranial nerve exam. No real findings on her exam, pretty much intact. This is her CT scan. Midline sagittal looks okay. Parasagittal looks okay. There's something kind of funky on this axial. I don't know if you can, you can see mine. These, you wouldn't typically.
These internal carotids?
These are not, these are bones.
These are bones.
Bones that you wouldn't expect to see at this level, but it'll be more apparent this was obviously very missed on the CT scan initially. It was read as pretty much normal. MRI scan, nothing really explaining her dizziness, vertigo, symptoms. Flexion extension x-ray, everything looked okay.
So let me halt you there, Dr. Tymchak. Dizziness, vertigo, super common presenting symptoms in a spine clinic. Any hints on screening exams? Any hints on what we should kind of order diagnostically if there's a persistent problem?
Well, I think you have to try to make a clinical determination of what might be the etiology or localization of where the dizziness or vertigo is coming from. And it's important to try to differentiate between those two words and get a real good descriptor from the patient of what they mean by their symptoms. If it's vertiginous, then, localizing more to the, inner ear, either peripherally or, more centrally into the posterior fossa. Whereas dizziness is oftentimes more, a presyncopal type of situation where people are getting either transient reduction, hemodynamic, reduction in flow to their brain in the worst case scenario, or for other reasons that are unrelated to, the neurovascular system, such as, just general metabolic condition or blood pressure issues.
Yep. Yeah, it was actually a further investigation into the nature of her symptoms that kind of led to the subsequent scan that led to her diagnosis. She noted that on further questioning, her symptoms were really only noticeable when she turned her head to the left. And this was able to easily reproducible in clinic. You would just have her turn her head to her left. And after about 30 seconds, she would start getting vertiginous, dizzy, have pain shooting down her arms, and confused.
And again, just clearly there's no cranial nerve findings.
No cranial nerve findings. So
this is a Bow-Hunter syndrome?
Almost.
Yeah, this is a styloid ossification.
Yeah, so this is a dynamic CT of her neck. This is a CTA with her neck in a neutral position and a CTA with her tucking her chin forward. And if you can see, I could only pick a representative slice, but her vertebral artery on the right disappears when she tucks her chin. So it doesn't seem to fill. And this is a reconstruction of her CT showing a dramatically elongated styloid process, which seems to, this is called Eagle syndrome. So an elongated styloid process, normally the styloid process under 3 centimeters, and this one ossifies and it kind of acts like a foreign body. This is an extreme cadaveric example of some alien styloid processes. Pathophysiology, I only have a few minutes. In terms of the surgical options for it, can actually be done intraorally. You can actually palpate them if they're exceptionally long through the mouth. And literally you just palpate it, make a nick, slide the mucosa over the styloid and then snip it off. But I've never seen that done. There's also a transcervical approach, which seems slightly more morbid. And as related to this Bow-Hunter syndrome, similar to Eagle syndrome, but not with an elongated styloid process. So positional vertebral artery occlusion.
So this is great. Any other slides?
That's it.
So no, thanks for sharing that. I think one of the key points for all of us is physical exam matters. Don't just look at MRI scans, and do provocative tests like simple looking up, looking down as far as possible, rotating to left, rotating to right, and see what symptoms replicate and what kind of stays inconsistent. Zane, have you ever seen this? This is a great case. Thanks for showing this. Mm-hmm. Zane, any thoughts on these kind of provocative tests and vertebral artery insufficiency syndromes?
No, I think, the history is super important because once you tease it out and get away from the general dizziness, vertigo terms, a lot of times patients will spontaneously tell you that it's every time I'm shoulder checking or every time I'm in this particular position doing, this or that, or laying in this position, that's when I start to get these symptoms. And that tips you off to a mechanical compression problem.
We got, I think Dr. Tataran got a nice CTA here, but is that the best first test, or what would you recommend for a standard spine practitioner to look at vertebral artery circulation? Are there non-invasive tests? I mean, CTA or non-radiating tests, I should rather say non-ionizing tests. Like, do we have Doppler, transcranial Dopplers, anything that can help us with that?
I think it is more dependent on the proficiency of the technician, though. So I think the standard CTA with or without dynamic maneuvers is usually going to be the first line, and then but Doppler of the neck with positional movements, if you have a good technician, you can pick this up as well.
That's in my time at UW and Harvard was always the go-to test, and Dr. Newell had created a very nice lab standard there for that. But the more I see this, the CTAs nowadays are so superior. Rod, any thoughts on that?
Yeah, I mean, these are rare conditions, but they do exist, and I think that clinical history is important.
Have you published that as a case report? I think that's worthwhile publishing because the styloid process ossification is impressive. I've actually seen it before, but this is a especially in the axial CT, very misleading because I thought this could be a calcified aberrance internal carotid or something like that. It's a little bit off laterally, but great case.
Go right ahead.
All right. Great honor to have our guest speaker here today. Thank you for our fellows for their grade 4 cases. Dr. Tymchak, please come up to the podium. And as introduced previously, Dr. Tymchak is a dual fellowship trained spine and vascular neurosurgical colleague. And he's from the University of Saskatchewan. He's a member of the Royal College of Physicians and Surgeons. And he did his fellowships with us at SNI. He's from Saskatchewan, as I said, and really exemplified the very high standards of education and care from his residency and medical school training. He's a proud father of 2 now, recently. And his wife is a practicing OB-GYN surgeon here in the area. It is really cool to have crossover talented and educated partners here because it's so nice to have people working side by side and elbow by elbow and being immediately available for consultations. We asked Dr. Tymchak to discuss vascular malformations and things pertinent to a spine practitioner in terms of what should we know and what are commonly asked questions and concerns. So thanks for being here, Zane.
Thank you for having me. I have no relevant disclosures today, and as Dr. Chapman discussed, I'm presenting this with the idea and aware of my audience. So not going to make it too technical or too nuanced, but more generally focused on what spine surgeon, how one might approach these lesions and, focus on investigations, clinical presentation, and then a brief discussion about management of the more common spinal vascular malformations. These are the objectives for today. So in terms of, why these are important to know about and important to have in the back of your mind, they're very rare. But if you're a practicing full-time spine surgeon, you're going to see these for sure. And these are one of these pathologies that can fool you into doing surgery for an abnormal spine radiographically, but maybe they don't fit with the patient's clinical presentation. And there could be something else, going on, very similar to what we just saw in the cases presented here. And you will see, if you're, again, a spine surgeon, you're going to see these patients that have had laminectomies done, and then they come to you and you're tipped off that there's something else going on. These are rewarding cases because oftentimes people come in in quite poor neurological condition. They've had a long progressive indolent history of progressive decline, and you can really make a big impact by promptly recognizing and treating it. These are challenging in that they are not representative of a single etiology. There's a very heterogeneous spectrum of pathologies that are represented under the umbrella of vascular disorders of the spine. And they, the lesions that are associated with shunts are very different in terms of their presentation and treatment than those that are, let's say, extradural, lesions or neoplastic lesions, for example. To get things started, we'll just do a brief review of the relevant anatomy of the spine and spinal cord in particular. The main arterial supply, as we all know, is segmental. And during development, you have your dorsal vessel that coalesces into forming the aorta, and then also the vessels that then supply the head and the neck. And they're parallel and run in longitudinal configuration and are extensively anastomosed due to this developmental phenomenon. In the cervical level, in a developed, adults, most of the supply is coming from the vertebral, ascending cervical, deep cervical, ascending pharyngeal occipital arteries. And there can be various normal anatomical variants whereby a prominent tributary or supply to the spinal cord arises from any of these arteries. In the thoracic, we have supply from the costocervical, sometimes the supreme intercostals, internal thoracic, and then the intercostal segmentals. You have the lumbar segmentals, median sacral artery, the iliolumbar system, and the lateral sacral vessels. And as mentioned, these are, even if you don't see these anastomoses angiographically, they're almost always there, and they're kind of waiting to manifest themselves in situations where the circulation is compromised. This is the relevant arterial anatomy that we're mainly dealing with in this discussion. And I have, this schematic annotated here. So you have your intercostal arteries, you have your vertebral branches that supply the actual vertebral body. Those are going to be important for neoplastic processes, metastases, and hemangiomas of the spine. Importantly, you have the radicular artery, which runs within the nerve sleeve and is the site of a lot of and the most common spinal vascular malformation of the problem. And then you have the anterior radiculomedullary artery supplying the ASA, anterior spinal artery, and then the posterior radiculopedial artery supplying the paired posterior cerebral or posterior spinal artery. Sorry. These are not necessarily, just parallel channels that are in continuity the whole way down. There's a significant amount of variability. There's more of a consistent midline configuration of the anterior spinal artery. And then in terms of the supply of the spinal cord, you have major sulcal perforating arteries, and then all of these circumferential anastomoses around the spinal cord that connect the posterior and anterior spinal arteries. In terms of the main contributors to formation of the anterior spinal artery and the posterior spinal artery, in the cervical region, you have usually 2 to 3 major radiculomedullary arteries making up the main supply of the anterior spinal artery. The largest is termed the artery of the cervical enlargement, usually arises at the level of the C6 nerve root. And variable sources will say it arises from the vertebral artery most commonly, other sources from the deep cervical artery. And then there can be additional contributions from the other arteries mentioned previously. On the left is an example of an angiogram, vertebral artery injection, and this shows the artery of the cervical enlargement. These arteries that supply the anterior spinal artery have a characteristic hairpin turn on angiography. And then in the A and B panel is the great artery of Adamkiewicz. And the artery of Adamkiewicz, I'll get to it again in a little bit more detail, but in terms of the location, they tend to arise between the levels of T8 and L2. Probably 80% plus will arise at those levels. They've been observed as high as T5 and as low as L5. Once they get out of that normal kind of T8 to L2 region, they tend to then become paired. So if you see one that's a little bit higher, there's a good chance that there's going to be another main contributor lower down. 80% of them will arise on the left side as well. In terms of the venous anatomy, here's a schematic cartoon describing the relevant venous anatomy draining the spinal cord. And then as spine surgeons, we're intimately aware and familiar with the epidural venous plexus and how rich that can be both in normal anatomy and certainly in pathology. So one of the confusing things about these spinal vascular malformations is the wide array of classification systems that you'll encounter when you're studying these and learning about them. And as with any classification system, a good one, utilizes a methodical approach to the lesions, and then also also in some way informs management. The attempts at classifying these have been, based on the anatomical location, either the space in which that the vascular anomaly or malformation is arising. So whether that's intradural versus extradural, intramedullary versus extramedullary, spinal, arising from the spine proper, and then also the angiographic features, i.e. which particular blood vessels are giving rise to the vascular malformation or supplying the vascular malformation. Some of these classifications divided more based on pathology. And then an important differentiator is whether the lesion is shunting versus non-shunting. So is there an abnormal arteriovenous connection? Because the shunting lesions tend to fall into their own kind of separate category. There are definitely some differences within that, but they tend to have more of a similar presentation versus the non-shunting lesions. This is a nice table outlining main classification systems. The one that I was sort of familiar with in training was this one here, the type 1, 2, 3, 4. And then Spetzler has a modified classification, which has been around now for a while. And this is more descriptive and is also a very nice way of approaching these. In terms of a practical approach, when you're thinking about it, I think it's always nice in terms of communication with your colleagues to be able to say this is a type, 1B type of spinal vascular malformation. But at the end of the day, using descriptors is probably just as helpful, if not more helpful. And so when I approach these, I think a good way to think about them is, figure out where they're located. So whether the lesion is intra versus extramedullary, whether it's intra versus extradural, because that's going to inform you about what type of lesion we're dealing with. And then is the lesion shunting or non-shunting? And you won't know that for sure until you've done an angiogram, but you can get some hints based on the non-invasive imaging. If you're dealing with a non-shunting lesion, chances are this is going to be something, more along the lines of a neoplastic process, such as a hemangioblastoma, or a vascular process such as a cavernous malformation, which we reviewed in one of the cases, or just an aneurysm. In terms of the presentation, spend the most time with discussing the most common of these lesions, which is the so-called type 1 dorsal, dural spinal fistula. And this is a drawing of these lesions. They typically they rise at the level of the nerve sleeve, the radicular artery, as it enters and pierces the dura, and there's an anomalous arteriovenous shunting connection, which shunts blood into the perimedullary venous system around the spinal cord. An important factor in this is that the venous system around the spinal cord and the spine is generally valveless. So there's that contributes to how these patients present, in that most of their symptoms are due to venous congestion. And that's contributes to this sort of indolent progressive course that we so commonly see. In terms of this particular lesion, this is by far the most common. Probably greater than 70% of all spinal vascular malformations are this type. And they're more common in men by a ratio of about 5 to 1. They typically present in sort of late middle age. And the vast majority are located in the thoracic spine. Like I said, most of the symptoms are attributable to this venous hypertension and congestion due to the shunt. but rarely they can present with sort of just isolated radiculopathy due to compression of the exiting nerve. In terms of what these patients present with, their course is usually indolent and kind of slowly progressive, but it is characterized by sort of sudden declines at times. Almost all of them will have sensory motor complaints. Clinical myelopathy is very common, as is bladder bowel dysfunction upon presentation. And the vast majority of them will also have a component of sort of pain, just back pain as well. And you can see the tip off to these is often in about 3/4 of patients plus, there's going to be a long segment of intramedullary T2 cord hyperintensity that will tip you off to this diagnosis. Less commonly, but also very helpful, is the presence of these T2 flow voids that you will see along the dorsum of the spinal cord. And this is the dilated paramedullary draining vein. That's what we're seeing there. Other lesions that we'll just sort of go through in more briefly are the true intramedullary nidal AVM. So these are also shunting lesions. They're fed by arteries that are going to supply the anterior spinal artery and posterior spinal artery. And they have an abnormal but intervening capillary network between the arterial side and the venous side, this nidus of irregular blood vessels. They can have a similar picture of presentation to the type 1 fistulas, but tend to present at a younger age. And in contrast to those dorsal spinal fistulas that we just discussed, they tend to be associated more with sudden decline in the setting of hemorrhage, oftentimes associated with an intranidal aneurysm or some sort of venous pathology that precipitates the hemorrhage. These ones are more commonly associated with genetic syndromes such as NF, Osler-Weber-Rendo, and Klippel-Trinani-Weber syndromes. They can be dispersed throughout the cord and typically in keeping with the volume of parenchymal tissue. So 30% within the cervical cord and about 70% within the thoracolumbar cord. These lesions are quite rare and are highly morbid on presentation. Most of them will have permanent neurological deficit. And because of their location within the spinal cord, surgery is much more morbid than surgery for the type 1 fistulas. This is the juvenile arteriovenous malformation type 3, classically associated with something called Cobb syndrome, where an entire metamere, so developmental, metamere of a segment is involved with this malformation. And these are going to present in younger people, can present in a setting of heart failure just due to the high flow shunting nature of the lesion. You can rarely auscultate a bruit over top, and they can be associated with nevuses on the skin as well, which can be a tip-off. Typically, these are managed in a multidisciplinary, multi-staged approach, and the goal being to reduce the shunt, to preserve neurological function and also to mitigate symptoms, because there's so many compartments in and around the spinal cord that are involved with this. They can have symptoms from myelopathy symptoms from venous hypertension. They can have hemorrhage. They can have mass effect as well. And so you have to, sort of select a portion of the lesion that you're going to treat. And rarely can they be cured. This is a very rare type of lesion, a peel AV fistula or paramedullary fistula. These involve supply from the anterior spinal, posterior spinal arteries. typically a ventral location, but can also be dorsolateral. And they don't have, in contrast to the true arteriovenous malformation, they don't have an intervening capillary bed or nidus. So they're a true kind of shunting fistulous lesion. They typically present with myeloradiculopathy, similar to the type 1 fistulas, although they present at a much younger age usually. And then hemorrhage is more common than that lesion as well, but less common than the AVM with nidus. This is a nice schematic outlining the more rare of these pathologies in one slide. In terms of the non-shunting lesions, we've already seen one of these today, but this is a cervical cord cavernous malformation. And as we discussed in that case, you can see that there's been evidence of previous laminectomy. So this was a case that we had here this fall where the patient had undergone previous laminectomy and attempted resection of the cavernous malformation, but they didn't get it all. Who knows what happened, but presumably they weren't aggressive enough. And it's tricky to walk that line between being aggressive enough to resect the whole lesion, but not too aggressive that you end up causing harm. Another common lesion that spine surgeons will encounter, and certainly patients have questions about based on their radiology reports, are spinal hemangiomas. And it's good to know that rarely these can become quite atypical and aggressive. This is a case that we did recently here of a patient that had his atypical T8 hemangioma treated back in the early 2000s with decompression alone and kyphoplasty, but then represented with quite advanced and bad cervical or thoracic myelopathy, and his MRI showed recurrence of his disease. These, if you don't resect the entire lesion, unfortunately, these can be quite recalcitrant to treatment and recur. This is a catheter angiogram at the level left T8 showing the vascular blush within the vertebral body. This patient went on to have embolization followed by subtotal resection at T8. And we also bridged his construct to include the lesion up at T4. And I think he's going to go on to have adjuvant radiotherapy as well. In terms of imaging, so when you're seeing one of these patients in clinic, oftentimes they're coming to you already with an MRI. And the typical situation is, you get referred this as a neurogenic claudication, spinal stenosis, kind of run-of-the-mill case. You walk in, you look at the MRI, and there's T2 signal change within the conus or the low thoracic cord. In that situation, you need to do more imaging, another MRI involving the thoracic spine with and without contrast. And you should also consider doing a time resolved sequence. So discuss with your neuroradiologist beforehand, what the local protocol is. Oftentimes this is enough to, in about 70 to 80% of cases, you can actually identify the level that's supplying the fistula, which can be super helpful once we take the patient for an angiogram. In terms of angiography, even to this day, catheter angiography is the gold standard for diagnosing these. But despite that, MRI and non-invasive techniques are really quite good now. And this is a case that I did last year of a woman, 80-year-old woman that came in with acute spinal cord injury in the setting of a subdural hematoma in the spinal cord. And she came in extremis was Asia B. But interestingly, she had had a transpedicular biopsy of this lesion several months beforehand. And we didn't have the luxury of getting an angiogram prior to surgery because she was in such poor neurologic condition. But there was suspicion preoperatively that she may have developed a fistula, potentially due to the biopsy. In retrospect, the biopsy was quite low in the pedicle. and probably violated the bony margin and may have caused an iatrogenic injury that then led to the development of this fistula. And intraoperatively, we were able to decompress the cord and also find an irregular appearing vessel along the dorsum of the cord that we sent for pathology. And based on the pathologist's interpretation, they thought it looked like an arterialized venous structure. So in keeping with a fistula. That was an unusual case because we, didn't have the time to work her up with an angiogram. But in most other cases, you should do an angiogram, refer that off to somebody that can do a good angiogram. These can be very challenging procedures, very tedious, particularly in older patients with capacious aortas, as well as atherosclerosis. It's sometimes very hard just to select all of the intercostals and segmentals that you need to get a true diagnostic test. But at a minimum, particularly in the more common, these type 1 lesions, which occur oftentimes in the mid to low thoracic spine, you do want to identify the level of the artery of Adamkiewicz. And this is, again, that characteristic hairpin appearance. And you can see the hemivertebrae here, the blush of the vertebrae. And so you can tell that this is right in the midline, and that's one of the best ways to identify the anterior spinal artery. In addition to that, in addition to identifying the main radiculomedullary radiculopedial supply to the cord, then you obviously want to find the lesion and characterize it. Where is it arising from? If there are multiple feeders to it, or whether it's just a single feeder. And then oftentimes in delayed angiographic runs, you can get a sense for the delayed washout of contrast due to the venous hypertension and congestion. And a really nice thing to consider if you're, planning on doing the surgery for this is to ask your interventionalist to place a coil at the level of the intercostal so that you can localize it very easily at the time of surgery. So that's a helpful tip if you're planning on doing this type of surgery. And then you're not going to be struggling with trying to identify the correct level, which we all know in the mid-thoracic spine can be very challenging. It's not an uncommon story to have patients undergo angiography and it turns out to be, negative. If you have a high index of suspicion that there's a lesion there and you get a negative angiogram, you basically have to bring the patient back and do it again. And you keep looking until you find something. And one of the more common arteries that can be ignored is the median sacral artery, which is visualized here. It oftentimes comes right off the crotch almost of the bifurcation of the aorta into the common iliacs. And fistulas arising from this artery are found in up to 10% of cases. So it's something that should not be ignored. And rarely even you have to do a cerebral angiogram and interrogate all of those vessels as well. In terms of the management, this is mainly focusing now on the most common of these pathologies and the one you're more likely to see in practice, which is the type 1 dural fistula. And again, just to remind us, it's characterized by classic stories, a middle-aged guy. He might have some lumbar spondylosis, maybe some spinal stenosis, gets referred to for that reason. It's sort of a grumbling progressive history, but is more characterized by myelopathy versus just radiculopathy or neurogenic claudication. It can be very challenging because they can also have positional variability and changes with exertion. So it's common to have a patient report that their symptoms get worse with exertion. And again, that kind of mimics neurogenic claudication. So the tip-off is the history, the imaging findings of the T2 cord signal change. And because of the aggressive natural history of these lesions, treatment is almost always indicated. Pretty much barring, the patient's comorbid condition, you're going to take this patient for treatment. In terms of treatment, even though we have great tools and techniques in the endovascular sphere, this largely remains an open microsurgical disease. In terms of the barriers to embolization, we've sort of briefly discussed them already, but there can be atherosclerosis and difficult access to get into the ostium of the feeding vessels. To get distal enough into the circulation to embolize it effectively, you might be nearing the point of the size of your catheter, i.e., it's not small enough. You have to get the embolic material into the foot of the vein or the proximal vein to really treat these lesions effectively endovascularly, and that can be challenging. And then in addition to that, you're certainly more wary about the collateral supply to the spinal cord. Anastomoses that were not recognized even on superselective angiography can all of a sudden appear once you start injecting your embolic agent. And that can certainly be a disaster waiting to happen.
Dr. Tymchak, we have a great question by Dr. Harshat Parekh, and I think you're probably going to go there, but I just wanted to kind of make sure that he got the answer. He was wondering if you have thoracic myelopathy due to fistula, what recovery chances does a patient with established thoracic myelopathy have after a successful intervention, whether it's embolization or microsurgery?
Yeah, I'll get to that. But basically, the rule of thumb is about 2/3 of patients will improve clinically, and maybe a third of patients or so will not get a whole lot better. And certainly the earlier you recognize the condition and treat it, barring any complications during surgery, the better.
Thank you. Sorry for the interruption.
Now, the location of these lesions is such that you often don't have to perform instrumentation and arthrodesis, although that should be something that you consider in your preoperative workup and assessment for what type of surgery you're going to offer the patient. But oftentimes we're dealing with the thoracic spine, which we know is far more rigid. You can do, a more generous laminectomy on a unilateral side, spare the other side a little bit more. Do things like that, limit the number of levels that you operate on, particularly if it's just fed by a single feeder. You don't have to do a super lengthy laminectomy, and hopefully you can avoid the need for instrumentation and arthrodesis. This is a intraoperative picture showing the classic findings that we see for these type 1 fistulas. This is the fistulus point right at the entrance of the radicular artery into the intradural compartment. This is the draining vein. So in this type of surgery, our goal is more addressing the venous side of the pathology. This is a ICG run during surgery showing early opacification or early filling of the vein. And then after surgery or after ligation, clip ligation and resection of a portion of the draining vein, you see that on repeat ICG angiography, there's no early drain. And these are, these can be very quick surgeries, very nice, clean surgeries when you have the right information going into it. So gathering that information is of the utmost importance. So in conclusion, these are very rare lesions overall. There's a heterogeneous spectrum of them, but you will come across a handful of them during your career as a spine surgeon. Most commonly, they're going to be these type 1 fistulas. You need to have your your vascular hat on, have a high index of suspicion, ask for help, ask your neuroradiologist what the next best test is if you're not sure. Get an angiogram if you're concerned. And these can be very satisfying surgeries, both from a technical perspective as well as from a patient outcome perspective. People tend to be very happy. And then just as a bonus, which I said I would discuss, this is mainly in relation to the artery of Adamkiewicz that Dr. Chapman was asking about earlier. So, the question: can a spine surgeon safely perform rhizotomy, for example, during a transpedicular corpectomy, which I think would be the most common reason why you'd do that? And there's a nice systematic review in Global Spine Journal from I guess now 2 years ago, but they studied the literature from both a vascular surgery, so those patients that were undergoing abdominal aortic aneurysm repair, as well as spine surgery. Interestingly, they showed much lower rates of neurologic deficit in the spine surgery cohort in those studies, and it was by a factor of 10. So it was up to 5% in the vascular surgery literature versus only 0.5% in the spine surgery literature. And their conclusion, based on both animal studies and their review of the available literature, was that it is probably safe to sacrifice up to 6 pairs, so bilateral segmental or radicular arteries, including Adamkiewicz, without prior knowledge of the vascular anatomy. The caveat and caution being that if you don't have to, don't do it. And I think the key takeaway here is understanding that there is a robust anastomosis that is present, but often not utilized until necessary. And so even if you end up having to take Adamkiewicz or the radicular artery that supplies that, you're probably going to be okay. Certainly, if you're considering that, then you should also try to use neuroprotective measures such as elevating your MAPS, potentially using steroids, keeping blood loss to a minimum, appropriate replacement of volume and blood products as needed.
Great overview, and thank you for the bonus. So appreciate you. We're going to give you an applause from the audience here. Got a very nice group. Dr. Harshad Parekh, thank you for all your questions. He's from Mumbai in India. He had one other question just for clarification again. Should you excise the whole fistula? Is this ligation enough to kind of decrease the mass effect?
I think it can be done on a case-by-case basis. It's certainly safe to resect the vein. That vein is not draining any normal spinal cord tissue. At that point, it's abnormal. But I don't typically just interruption of the fistula is enough.
Great. And then one more question, and we have to close. Thank you again for coming. So these segmental vertebral angiograms. So when I was a younger attending, that was in the last century, shamefully to admit, that was considered kind of a dangerous procedure because there was a certain amount of infarction attributed to that particular test. I think the numbers were as high as 5%. I saw even higher ones than that. But that was kind of, even in our board collection period, something to discuss very carefully in terms of when do we do that or not. I see you guys now do these segmental angiograms with effortless ease and even multi-segmental studies. So tell us a little bit about, is there an infarction risk and how can you localize and how many levels can you actually do a selective angiogram for?
So I think in terms of spine specific, the rate of, the incidence of spinal cord infarct is exceptionally low. And these angiograms are very safe, although they can be technically challenging and tedious. In terms of interrogating the vertebral arteries, I think the traditional teaching is a risk of 1 in 200 in terms of risk of stroke with a diagnostic catheter angiogram. I think nowadays in practice, that number is much more favorable than that even. And the risk is going to go up with the expected vascular comorbid risk factors, age, vascular anatomy, and in those patients that are for one reason or another hypercoagulable. And certainly appropriate and judicious catheter use with either a double flush of the catheter, aspiration of the volume of the catheter and flushing it with a heparinized solution, or with continuous heparinized saline during the procedure is appropriate in select cases. But I think if you're thinking about an angiogram and you have a clinical reason why you might want it, and you have somebody who is experienced, don't hesitate, because it can really provide you with a lot of useful information that comes in handy if the worst case should happen during surgery.
We must close. Thank you. Really underscores the value of having interdisciplinary and expanded knowledge, and having a deep appreciation of the complexities and the amazing features of the spine. And certainly vasculature is an eminent part of this and should not be forgotten. Really appreciate you and all the daily collaborations that you have.